Okay, good evening, everybody, and just greetings and salutations, people who might be in different time zones around the country or even overseas. My name is Philip Ash of Grin2B Foundation, and welcome to the first live webinar of Grin2B Hive Webinar Week. This webinar is entitled Simons Searchlight Registry Updates and IPSCs. And so really excited to bring this to you. Tonight's presentation is going to be done by Dr. Wendy Chung, MD, PhD. She is the principal investigator at Simons Searchlight. She's the director of clinical research, SFARI and Simons Foundation. During this talk, Dr. Chung is going to present some updates on Simons Searchlight, the Grin2B research registry, including a summary of the medical, behavioral, and developmental data that's been collected thus far. In addition to a registry update, she's going to discuss the importance of IPSCs, which stands for Induced Pluripotent Stem Cells. And those are collected by participating families via blood samples. And those blood samples are used to create those pluripotent stem cells, and then they are distributed to interested researchers. And so tonight's talk aims to highlight the value of research participation for you and your family. A couple things before we begin, and before I turn things over to Dr. Chung, I'm going to ask everyone if they would to, during the presentation, to have their cameras and microphones off, just so that it'll kind of help the recording work a little better. Also, if you have questions during this presentation, please feel free to put that in the chat. There will be some time following the presentation to answer some of those questions. I'll do my best to moderate and navigate through those. This presentation should be around 45 minutes. And then, of course, we'll have some time at the end for questions. And of course, if you want to ask your question more one-on-one, or if you think of something towards the end as we go through that, that's totally fine. We'll just kind of take this as it goes. And with that, I just need to do one more thing here, and then we can get started.
Just let me know when you're ready for me to start.
Yep, will do. Okay, Dr. Chung, you can begin when you're ready. Thank you.
Okay, very good. Hopefully everyone can see my slides, and if it's helpful to have these slides afterwards, we're glad to provide them. So thanks, Philip. As you said, I'm Wendy Chung. I'm a medical geneticist. I'm based at Columbia University as well as the Simons Foundation, and I'm going to be sharing the data today about Simons Searchlight, and to say that I'm here representing really a huge team of people behind you, some of whom are on the line with me today. But this has been very much a team effort, and we consider this an opportunity to help your research go forward. So we try and make this easier for really good researchers to work on Grin2B, and I'm going to give you some updates in terms of what they and we have been finding. So Simons Searchlight has been around for 10 years now. We're celebrating our 10th anniversary, and I can say I was there at the beginning in terms of getting this forward. And it's evolved over time, but it's remained true to the mission in terms of trying to shed light on these conditions, not only GRIN2B, but also other related neurogenetic conditions, and really help to provide high quality research data to researchers who can move things forward. And in fact, in some cases right now, we are funding and reviewing grants that are funding those researchers. So it's not just providing the data, but also dollars for them to work for you to get the job done. As we're doing this, I want to reassure everyone that all of the data that we're sharing, for those of you who have participated, is de-identified. So no one knows exactly who you are, but I do know that they care very much about you, and they're always very moved when they actually get to meet families or when they hear about your stories. So if you do have a chance, do share that with them. We also want you to be the researchers, Dr. Mom, Dr. Dad, Dr. Grandma, and Grandpa, to be able to learn from this, and that's what we're about here tonight. So the process itself, I admit, is sometimes hard to understand. And so we've got coordinators on the line. And then if you go to the Simons Searchlight website, there's both an email and a phone number if you feel like you've started doing the process, but maybe you got stuck, and maybe some of the stuff I'm presenting to you tonight doesn't sound like what you did. It may be that you started the process, but haven't quite gotten as far as the steps I'm going to present data about tonight. When we think about this, we've had a little over 100 individuals in the GRIN2B community register with us at Simons Searchlight. The process, the first step is that we review a genetic test report to make sure you're in the right group, that really GRIN2B is your home. And it's almost always the case, but occasionally we find someone who really belongs in a different home, and we want to make sure they get to that home and have the right information for them. One of the things that I think people find very helpful is that we have a team of genetic counselors who are there to talk to you. And I think that's really helpful for them to be someone who actually knows the condition. So I know many of you may feel alone because you feel like you talk to your doctors and they've never heard of this condition. They have no other patients with this, and giving you access to medical professionals, genetic counselors who know about your condition, I think can be quite helpful. We've tried to make this available to anyone around the world. We're constantly adding new languages, and do tell us if there are GRIN2B pockets in countries we may not have thought of in terms of languages, but we do try and make this as accessible as possible. And beyond talking to someone on the phone, we appreciate that some of this may not be so convenient to do at the hours of the day. We have genetic counselors manning the phones, and so we have also online surveys that can be done 10 o'clock at night, 6 o'clock in the morning, whenever you have time to be able to work on them. And this is something that we continue working with you long term. So we are dedicated to continue with this on the journey for years and years and years. As I said, we've been at this for 10 years already, and I think we're going to be at this for many more years to come. So we do send out annual surveys, and as I'll show you in the end, part of this is that we want to understand how things change over time. What someone's like at 2 isn't what they're like at 12 or 22, and we need to understand how those features change, and in particular, if there's anything that we can do to help folks get onto the right course. And if we can share that, if we can think of life hacks, if we can think about best practices, if we can think about clinical care guidelines, all of those things to be able to allow your child, your family member, your loved one be the best that they can be, that's what we're trying to do. Within this, we also have families who have provided blood samples, and I'll get to why that's so important. Philip mentioned the induced pluripotential stem cells, and that's something that we realize, listening to the research community, can be very valuable, but difficult to make. And so we've tried to help provide that to the community. So as I said, in terms of looking at this, we've had many families provide samples for GRIN2B. I'm just going to show you this whole process in terms of how this happens. We have individuals who can go to, in the United States, a local Quest laboratory to get their blood drawn. Again, we pay for all of this, but get your blood drawn, and then it gets shipped to a laboratory that can make the induced pluripotential stem cells. But what you get in the mail is your kit. You go to a Quest laboratory, that gets shipped back, as I said, free of charge. Happens to be to a biorepository in New Jersey. We at the Simons Foundation then pay for those to be made into pluripotential stem cells, and I'll explain what that is in a minute. But that process takes a while. It takes between 6 and 9 months. And again, that gets de-identified so that no one knows who you are, but researchers around the world can then use that sample for a very, very small fee, a little over $100 to basically pay the shipping cost. Why is this so important? And what are those IPS, ABC, QRS? I'm making fun of myself, but these induced pluripotential stem cells are iPSCs. Believe it or not, we can take blood cells and we can make them forget that they're blood cells and de-differentiate them or make them into cells that have, we call them pluripotential. Pluri meaning many, and potential, the ability to be many things, almost any things in terms of cells of the body. So we use some molecular trickery in the laboratory to do that, help them make them forget that they're blood cells. And then individuals in the laboratory, scientists, often neuroscientists, can take those pluripotential stem cells, those cells that could be anything. They're, they can grow up and be anything there are in life, and they now differentiate them or make them become brain cells, oftentimes, at least for GRIN2B. Those brain cells you can then study in a dish. So you can study in the laboratory without having to do a brain biopsy or take a piece of someone's brain out to be able to study it in the laboratory. You can even make mini brains. So you can grow those brain cells, you can let them develop and form what we call organoids, and they can actually make mini brains. And they literally do look like little brains about this size. They're not quite as perfect as our brains are as people, but they're a model, a decent model in terms of how this is. And if investigators, researchers wanted to do things like try a drug and see if the drug has the effect they're looking for, it's a very good way to be able to test those without having to put people in harm's way. So as an example, when companies are trying to develop new treatments and new drugs, sometimes they don't work. Sometimes, even more than not working, they could do something bad. They could have a toxic effect on the body or on the cells. And so this is a good way to be able to screen out those things that might actually have a bad effect and be able to make sure that we're looking or we're taking forward medications that might be effective. Again, it's not a guarantee until we try it in people, but try and separate those out in terms of those that are more or less likely to be successful. So that's what that process is about. As I said, this is, from my point of view, an incredible resource because each one of you who have donated samples, this is literally over $10,000 worth of investment to make your cells into these very fancy iPSCs. But by doing that, you can then be represented in research around the world. So within this, and this is just in case any researchers happen to look at this later, we've made a catalog of all of the GRIN2B. So this is very specifically just for the GRIN2B community, the different variations, the different genetic differences within GRIN2B that have been made, or I should say are being made right now into iPSCs. You'll notice that each one of these is unique. So we have specifically made sure that every one is different, with the exception of this last one here. And as we're doing this, we wanted to make sure this was broadly representative of the community of different genetic variants that we see in GRIN2B. So this slide is a little bit overwhelming, and I don't care that you absorb all of it. But what I do want to point out in this slide and the next slide is the diversity. So how much difference there is in terms of the community, even though everyone has a GRIN2B genetic variant, the actual variants, the actual address, the actual genetic difference is quite different in the community. There are a few of you, a small number of you that share the same one, but almost everyone is different. So which ones are the same across the community? We've indicated in this column here if there's more than one person with the variation. So 2 people with this one, 4 people with isoleucine 751 threonine, but you get the idea. But most of them you'll see there isn't a number here, and that's because you're special. You're unique. You're the only person right now in the GRIN2B community that has that particular genetic variation. Why is that important? In those cases, you are the only one who can represent yourself in the research. So if you think about those iPSCs that I talked about, if you're one of these solos, one of these individuals who's unique, there's no one else in the community who can replicate your genetic variation. So there's no one else who can be serine 541 arginine except you, if that's your genetic difference. And so if you want researchers to be able to test a medication or test a new treatment to see if it's going to work for you, you need to be represented. You need to get your cells in, you need to get your information in, because that way they're working for you. On the other hand, I can't, I don't want you to feel any sort of pressure that you have to do this. I want to be very clear. It's all voluntary, but this is the opportunity to make sure you and your family are represented in this research. Now, a little bit of technical detail, and I'm going to go into this a little bit more in the next slide. Some of you that may be aficionados will know that this middle column here is showing the exact genetic variation. This number in the middle tells you the street address, and this gobbledygook on the left, these 3 letters are telling what amino acid is usually in that position and what different amino acid is substituted. These are all we call missense variants because they're very subtle changes in the protein, just one little substitution of an amino acid. There's some of you that have slightly different types of genetic variations. In these particular cases, we call these frame shift or nonsense or truncating. In these cases, we think that the GRIN, at least one of the 2 copies of the GRIN2B is actually not working at all. It didn't show up to work, and instead of having the normal amount quantitatively of GRIN2B in your cells, we think there is half the amount, or 50%. So, and I should have said over here for these 2 cases, or these cases with the missense variants, there's always 1 copy of GRIN2B that's the same as everyone else, and then there's 1 copy of the GRIN2B that's different, that has this genetic variation. So with this, just to show this one more way, and then I'll move on to things that are probably more interesting to you. Let me see if I can advance my slide. There it goes. So this is just a pictorial, a graphical way of representing what I was showing you before. Some of the scientists prefer looking at this because it's a way of seeing the distribution of where the genetic variants are. It's kind of hard to put that whole table in your head. So visually, I'm sort of stretching out the gene. I'm showing important domains or regions of the gene, and each one of these little lollipops or each one of these circles is representing a person. And what you can see when some of these lollipops stack up upon each other is that at that particular position, there's not just one person, but 1, 2, 3, 4, 5 people, for instance, with this particular variation at that position. So this is, again, for the researchers who are thinking about how GRIN2B works, what are the important regions, pores, domains, it's helpful in terms of being able to visualize that. Okay, now let's dig down into the things that I think are probably most meaningful to you. So this is now reviewing some of the medical information and developmental information. And this is what we have from Simons Searchlight. It is representative of 46 individuals in the GRIN2B community. And that's, I think, a very good number in terms of being representative. It is biased, though, and I want to be very clear about this in terms of over-representing, I think, individuals who are young. So these are almost exclusively children, less than the age of 18, and even more so represented by individuals less than the age of 10. I'm showing age on the x-axis here, and then the number of individuals on the y-axis here. So you can see we've got about 15 people age 0 to 4, about 15 people ages 5 to 9 years, and so on. So one of the reasons that I bring this out is that it's not that I think that people with GRIN2B don't live to be 20, 30, 40, 50. It's that they don't know they have the diagnosis. They're sitting out there and they may have problems in terms of some challenges or health issues or neurological issues, but they've never had the genetic test that you have. And so because of that, they don't know that they belong in this community, in this GRIN2B club. So they're out there, but right now we have a dearth of information. And that is one of, at least for me personally, one of my big goals is to be able to help you know what life looks like 20, 30, 40 years from now. So that's still a gap that we need to fill in. Needless to say, what do we know? Because I do think there's quite a bit we know. In some cases, I don't think this is going to be surprising to you. And to me, that's the good news, is that I don't think we've learned things that are medically surprising. I don't think we've been really shocked by anything, but I am going to point out what we're seeing. So this is the percentage of individuals on the x-axis here, and then I'm showing you the different characteristics on the y-axis, and that'll be true for the next couple slides. So the first is that we're seeing basically everyone with some degree of developmental delay or intellectual disability. In other words, it takes longer for people to learn how to walk, talk, do various different things. But my point that I want to make is it's a positive slope. And you'll see this with some of the other slides I'm showing you in a bit. Kiddos make progress. It's slower than others for sure, but it is steady, it is positive, it's not plateauing, and it's not declining, it's not going down. So that's really important to me, because we just need to keep at it in terms of the best educational strategies, the most effective educational strategies, and to be patient. For many individuals, this manifests early on as language impairment. So I'll also give you some advice I've noticed from my own patients with GRIN2B is that their understanding or their receptive language is oftentimes much better than what they can say and speak, especially when they're young. They're actually understanding and processing a lot of this, but getting the coordination of getting your lips, your tongue, your teeth, your throat, getting all of that to work together is really challenging. That takes some time to learn that and to be able to express it using words. But when it comes in, it definitely gets easier over time. But I guess my point is for those of you who have little ones, don't think that they're not listening and they're not understanding what you're saying. One thing that we spend quite a bit of time at the Simons Foundation thinking about is autism. And there are a significant fraction of individuals, about a quarter of individuals who have autism or autistic-like features. There are also some other challenges, and I think to a certain extent, these change over the life course. I'll show you some of that in a second. But hyperactivity or attention deficit, a minority, but it can be seen. And then a couple kiddos with anxiety or obsessive compulsions. Other things that are related to what we as doctors sometimes see and you as parents sometimes see in terms of the effect of the brain on the body is that we can see especially low muscle tone or hypotonia. I often see that most in the trunk in terms of the core and the core strength, and why many of your kiddos work really hard in physical therapy. It sounds a little bit counterintuitive, but some of them can also have high muscle tone or hypertonia. And I tend to see that more in the arms and the legs. Many of you are aware that coordination problems can be a challenge. So being able to be graceful and smooth in terms of movements, it takes practice. But with that practice comes motor memory, comes increased ability to be able to do this. But in the early days, it can sometimes lead to spills and falls and accidents and sometimes injuries as well. And I'll get to injuries with eyesight in just a second. But it's important in terms of being able to make sure the environment is safe also for our kiddos. For some of them, we can see things that are less frequent and not very common, but we see everything from a large head size to a small head size to some types of movement problems, either problems, again, with maybe not being so coordinated or being a little bit wobbly or having an eye blinking. And some individuals had reported cerebral palsy, although I don't know whether it's actually just spasticity that some people think of when they think of cerebral palsy. So that may also be related to this high muscle tone area. One area that's really important to me is the epilepsy. I'm very thankful that it's not the majority of individuals in our GRIN2B community with epilepsy or seizures. Across some of the other GRINs, there's a higher frequency of seizures, but I'm focusing only on GRIN2B tonight. With this, we see various different types of seizures. So the most common, thankfully, are not the tonic-clonic jerking or grand mal seizures. They're things that are more subtle. But the reason I bring this up is because sometimes people can miss them. The petit mal seizures are oftentimes look like you're spacing out. You're kind of just daydreaming, you're out there, and it doesn't last very long. And so they may be missed as seizures. A piece of advice, though, is if you see something you're worried about, you're not sure whether it's a seizure or not, grab your phone, take a video. If your child is in a safe place, and if you have your wits about you and or someone else to help you do this, and share that with your provider, whether it's your pediatrician, your neurologist, your developmental pediatrician, but share that and see whether or not they think that's a seizure. And if there is concern, then an EEG or electroencephalogram is the best way to be able to see whether or not that really is a seizure and whether it needs to have treatment with medicine. But again, in a good way, seizures are not that frequent. There are some other medical issues that I think are related to the brain and the effect of the brain on the body in many cases, but it may not be quite so obvious what that connection is. So let me try and take you through it. Number one is that a majority, this is set up the same way again, percentages here on the x-axis with the different symptoms. Tummy trouble, very, very frequent. 3/4 of individuals have some sort of gastrointestinal problems, either constipation or diarrhea, occasionally gastroesophageal reflux or heartburn, very, very common. In a good way, there are ways of between diet, schedules in the day, and medicines in some cases. There are ways of being able to deal with this, but I will say this can kind of come and go a little bit. This can get worse at sometimes and sometimes get better when you can find the right rhythm or the right diet, whether it's plus minus lactose, pluripotent juice, fiber for some people, dairy for some, not for others, gluten for some, not for others. It's not a universal formula I can give you in terms of what's going to work, but it's a little bit of trial and error until you get to the right spot. But again, it can definitely get better. Antibiotics, I will say, tend to upset the what we call microbiome or the bacteria that are in the intestine. So if you do end up using antibiotics for an ear infection or something else, it may kind of disturb things and you have to get back to normal. We are seeing some issues, and this was an important point I wanted to bring up next with the eyes. The eyes really are the window into the brain, literally. It's where we get a lot of our eyes and our ears, a lot of our sensation that we use to learn and take in the world around us. And so it's critically important that eyesight is the best that it can be. In some cases, you can recognize it. You as Dr. Mom and Dr. Dad can recognize that the eye is a lazy eye. It may be turning out, it may be crossed, may only do that at the end of the day when your kids are tired. But when you do start seeing that, it is a good idea to take your child to a pediatric ophthalmologist, ideally one who takes care of children with special needs. And in some cases, that may need surgery, not an urgent thing. Urgency, but there can be surgery done to be able to tighten up the muscles around the eye, get them aligned so that they really are seeing with both eyes, which gives better depth perception, which helps in terms of safety, knowing where your body is in space and being able to make sure you're not bumping into things. Some individuals may have other things. So I wear glasses as an example. Some other kids need to have glasses as well in terms of what we call a refractive problem. The eyes just are nearsighted or farsighted. Then again, being able to make sure that that's taken care of. And again, a pediatric ophthalmologist, especially one for special needs, is oftentimes best able to look at the eyes and make those determinations. From a health point of view, largely it's good news. Occasionally, especially for little ones, there are issues in terms of growth. Either children who are picky eaters or have the tummy troubles may have some difficulty gaining weight. And so some of the parents talk about failure to thrive. And really what they mean when they say that, or your doctors say that, is just that they tend to be a little skinny. They tend to, not eat as well and not put so much weight on. But again, these are things that once you take care of some of those tummy troubles and get that diet sort of balance back in place, things tend to get better over time. There are some orthopedic issues as well, and these do change a little bit over the life course. Scoliosis or curvature of the spine is something that we see oftentimes when the children are getting a little bit older. So adolescents, or as they're going through puberty and going through a growth spurt, whenever that growth spurt might be, those are times when that comes out. And again, it's something that can be easily treated. A pediatric orthopedist or bone doctor is the best person to do that. Easy to look at the back. Sometimes an x-ray might be needed to see exactly how severe the scoliosis is, but better to catch it early and treat it early. I prefer, when we can, to treat it with bracing rather than surgery. Spinal surgery for scoliosis is a big deal for kids. And so we want to try and get in there before it gets to be that severe. So with this as an indication of how serious problems were, we asked the question, what medication are you taking currently? If something was serious enough to take medication about, then we take that even a little bit more seriously. So with this, just to see what fraction of people are taking medication, it's overall, and one person could be taking more than one medication. So this doesn't necessarily sum up to 100, but the most common was for the tummy trouble, the gastrointestinal problems. So beyond diet, for instance, beyond a particular routine, in some cases, like I said, things that help move things along, something that might be an enema, or something to help with the reflux. So those were most common. Within this, for seizures, about 15% of individuals needed seizures in some way, or needed medication for seizures. And I'm showing here on the right, we asked folks what was the most effective medication for those individuals who talked about having a history of seizures that needed medication. And what you'll notice here, and these are small numbers, so this is absolutely, I'm not telling you go home and change your medication to valproic acid, because these are small numbers. And what you can see was that, to me, there's no clear winner. It's not like there is one single epilepsy medication that everyone responded to. And so if you are taking medication for seizures and you're stable, that's the right medication for you right now. We did see some other medications for whether it be problems with behavior or other issues. I do think this can change over the life course. And so just continue as your child grows up and evolves. In some cases, issues with attention and being able to attend and be able to learn, occasionally needing medication for that. Some issues in terms of behavioral issues and needing something like an antidepressant or cannabidiol is something I've seen used more commonly. This has now become medical marijuana that's been legal in many parts of the world, but not all parts of the world yet, and is something that providers are getting more used to both prescribing and getting experience with. And so I'm not saying immediately go out and ask your doctor for this prescription, but just to say that there is some level of experience that's necessary to work with this, and your doctor may or may not have done that before. Okay, let me switch gears and now talk about some behavioral and developmental data. So our psychologists at Simons Searchlight did a great job in terms of thinking about how things change over time. So what I'm showing you in the next few slides are age on the x-axis. So along the bottom here is as kiddos are growing up. This is using a measure that you filled out called the Vineland. And I'm going to show you a few different domains, but this is about expressive language. So basically talking. Each dot is a different person, so each person is represented here. And what we've done is made a line showing the average for the entire group. And of course, not every dot, not every person lines up exactly on this line, but it's showing you what we think of as, some of you may know the growth charts that we use as pediatricians. This is, you can think of as a developmental growth chart. How are kids growing in terms of their ability to acquire different skills? Because sometimes people that have little ones will ask, for instance, Dr. Chung, my child's not talking yet. When are they going to start talking? When are they going to be able to, really communicate with me? So every child is different. I want you to appreciate that. But the main point that I wanted to show you is that kids are, again, I told you they're improving over time. That's what we're seeing. They're improving over time. They're making strides in terms of being able to use their first words, asking a simple sentence, and even going on from that. With some kids, I mean, a 10-minute conversation, that's a pretty intense conversation that many of, or at least a couple of our older kids are getting to the point of doing. We also looked at the dimension of, and I think of these as everyday practical things to be able to do, to be able to live your life. So as we think about this now, personal care skills. So again, what you need to do to take care of yourself, again, set up the same way with age on the x-axis here. What you will see is some variability. So when we think about things like using utensils to eat, being able to help getting dressed or undressed or shower and bathing, there's some variability. And remember, as I said, we don't have as many of the older children. Some of the older ones in the group are achieving, I think, some important self-care skills. We do, however, have a couple kiddos who are now adolescents who are still slower in terms of their advances. I'm going to make a prediction, and I think I'm right about this, but we'll see, that those who are diagnosed younger and earlier and getting intensive treatments and therapies when they're younger, I, in my practice, am seeing that they're doing better later on. And I think they're just generational differences, so that if you do happen to meet GRIN2B folks that are age 20 and older, what they had as infants and young children in terms of therapy and educational systems, to me, it's just a world of difference from what our kids growing up are getting now. And so I do expect there's going to be a generational difference with our young ones here, actually surpassing perhaps what we're seeing, at least in some of our older ones. So we'll keep our fingers crossed and hope I'm right about that. We're also looking at social development. So how do people actually interact with each other? And so some of you that may have been worried about autism or autistic-like features, again, it takes time to develop these skills, but people are developing skills in terms of being able to help work with someone together. So being able to do something in the kitchen, working together, being able to work on a task. You can think about working in the yard or doing something with a family member, playing with friends, but there's some people that are, again, making good progress in terms of moving forward, but there is some variability. And I do think some of that variability is based on the particular genetic difference in GRIN2B, and that accounts for some of the differences that we see in the community as well. Gross motor skills are one of the ones that's more challenging, I will say. So this is, again, it's a few less individuals just based on the way this instrument works. But things are a little bit slower when it comes to the gross motor skills. So again, walking, this is this dotted line down here. People are achieving walking in terms of hopping or jumping. That takes a little bit harder. And then things like catching a ball, that is possible, but it's going a little bit more slowly and taking a little bit longer in terms of doing that. But important, very basic things like walking, running, things like that, definitely coming in. Okay, the last slides I'm going to talk about, and then I'm going to wrap it up, are behaviors that sometimes parents get concerned about. And the news here is good. So I want to reassure people. So this is broken down by young children and then older children. The young children are age 1.5 to 5. And this is, again, using some questions that you answered called the Child Behavior Checklist. And concern, I want to point out, is this level here. So you can be all over here, but if you haven't hit the level of concern, then I'm not really so worried. So not a concern is where we're falling for the little ones. In a similar way now, but with the older ones, age 6 to 18, again, concern is over here, and we're not seeing concern. A little bit of difference in terms of things, but in general, it's not a level of concern at this point. So when we were asking parents about, particular behaviors that they were seeing for the young ones, we were hearing some things about sleeping a little bit less, having trouble, overnight, chewing on some things that maybe weren't food, not the best things to be chewing on, or problems in terms of restlessness or attention issues. And then with the older kids, again, some of the attention issues we talked about, just needing a lot of attention, having some trouble with impulse control and being fixated on certain things. So the very last thing I'm going to show you, and as I pointed out, we are looking at things over time. So we're looking at the same people on an annual basis to see how they're progressing over time. And this is using that same child behavior checklist with these sort of cutoffs here, either mild concern or significant concern. The important point is most people are staying below the level of concern. And for most of them, it's not just one time point. They're staying and they're maintaining below the level of concern. But one of the things I do want to see is for individual folks, how things might change over time. And this last year with COVID, I think has just been a sort of wonky year for everyone. So there may be some blips and things where they may be concerned for a period of time, but it may normalize after things get back to normal. So overall, in terms of now looking at some behavioral concerns, overall in terms of externalizing behaviors or things where you might see some tantrums or some yelling or screaming or things like that. Again, there are a few folks, thankfully not the majority, but that are in a level of mild concern. So just to wrap up, again, in terms of the news to me is probably what you already realized, and otherwise to me reassuring that the kids are continuing to gain strides over time. The medical issues are relatively minimal, although I don't mean to discount anything in terms of tummy troubles or, for instance, vision issues. Those are the ones that I would focus on. But in a good way, we're seeing that otherwise individuals are generally healthy and generally happy kids. So I will stop there and we can open it up for questions.
Dr. Chung, thank you very much for your presentation, and thank you to Simons Searchlight. Really appreciate that, and hope helps to shed some light on sort of what you're finding through these studies. With that, I've noticed there were a couple of questions in the chat, and it looks like some of the questions have been answered. We have a family in Canada, so trying to figure out how to get them to participate in this process. And so, Michelle, I hope that question has been answered. Are there other questions specific to Dr. Chung's presentation? You can either type them in the chat, you can unmute. I'm just going to pause here for for a little bit to see if we have any.
So I see a question about, can you explain the variant classifications? And I'll be glad to do that, Michelle. So for those of you who were, and obviously, Michelle, you were looking very closely, which is great. We have a very, and I apologize about the technical terms, but we have a way of looking at genetic variants to try and determine whether we think they're associated with a disease or not. And the reason for this is that we all have genetic variation. If I were to compare your DNA to my DNA, at about every 1,000th address, you and I will have a difference. And it doesn't mean all of those are problematic, they're just differences. So we try and bin these or classify these literally hundreds of thousands of genetic variations. And for GRIN2B in particular, because that's what we're talking about tonight, we've binned them into one of 5 categories. So at the one extreme, we talk about benign, meaning they're just normal differences. We don't think they cause any difference in health or the way the body works. That's at one extreme. The other extreme is what we call pathogenic. In other words, we're very certain that this is actually associated, this genetic change or difference in GRIN2B, actually associated with a change in the way that protein functions and a change in the way the brain works. So those are at the 2 extremes. If I then come, and we're certain of those are, from our point of view, in theory, we're 100% certain at the benign end, and we're 100% certain at the likely or at the pathogenic end. We then come in from that and we add the adjective likely. So likely benign or likely pathogenic. And what that adjective of likely adds there is about 10% wiggle room. So it means that for likely pathogenic, we're about 90% certain that it's actually causing the condition that I just described. So those are still, for us, pretty good odds. Being 90% certain for us, we know people are generally not perfect, and 90% is pretty good. Then there's this, what I call genetic purgatory. So that's the middle of this, which is variants of uncertain significance. They're genetic variants, and we don't know whether they're more on the benign side, more on the pathogenic side. We need more information to be able to adjudicate these. That is, that there's other bits of information that help us understand whether they should be one way or the other. So what are some of those important pieces of information that either you can do or did do to understand this? Well, one of the pieces that's really important is that if we see that this genetic difference in a child with a developmental condition, if we see that the child has it and neither parent has it, that is, that if it looks like it's de novo or new in the child, that's actually a really strong piece of evidence that we look for, and that actually makes it sway on the pathogenic side. So that might move something after we did testing in the parents from being uncertain to being likely pathogenic. And just on the opposite way, if we see it in a child and then we test the parents and we don't, and we do see it in one of the parents, we see it in mom or we see it in dad, and mom or dad, whoever has it, is neurotypical, they don't seem to share those same problems, then that shifts it in the other direction to being likely benign. So that's why for some of you, when your genetics doctor or someone did the testing, they had you as parents either participate in it at the beginning or at some point down the road to try and make this adjudication one way or the other. GRIN2B happens to be a tougher gene for us to be able to understand some of these ones that are in purgatory. So the reason I say that is because without the parents, several of these missense changes, these single amino acid substitutions, we actually don't have functional data to know how this protein works. And we haven't looked at every single amino acid through the protein. We haven't done what we call saturation mutagenesis yet. So in those cases, we make predictions. And I know this sounds maybe like a cliche, but believe it or not, we use machine learning, we use artificial intelligence by looking at millions of other genetic variants and knowing how they act and trying to infer or make our best guess about that genetic variant in GRIN2B. We're getting better at this. I can just say in my lifetime as a geneticist over the last 20 years, we've gotten much, much better at doing this, but we're still not perfect. But that is an important level of evidence to be able to say our predictions, our mathematical modeling, our computer modeling would make this sway either on the side of being likely pathogenic or leaning towards the side of being likely benign. And in many cases, that's the best we can do right now. Some of the researchers, though, and again, I'm going to come back to these induced pluripotential stem cells, some of the researchers are actually working on these exact genetic variants that your kiddos have, though. So they're willing to look at exactly that change and understand how that's changing the protein function. And that functional data, actually looking at the biology of that to seeing how that works, that's another strong piece of evidence to be able to put it over on the pathogenic side or put it on the benign side. So those are the three general causes that we
Everybody can hear me. We're having some tech difficulties. Let me see if I can recover this.
Oh, Philip's back. You
Looks
didn't
like
miss
we're back.
anything.
Sorry about that. Technology is wonderful until it doesn't work. And see, do we have all our participants back? Yes, it looks like I see everybody. So I'm trying to remember exactly where I lost you, but you had pretty much wrapped up. You were mentioning, you were discussing basically.
Yeah, so it's just in case the recording missed it, I'll say it one more time, that for, if you think of all of the variants of uncertain significance that come into a clinical laboratory, about 90% of those at the end of the day get adjudicated to be likely benign. So the majority of ones that are in purgatory end up being likely benign. It's not to say that everyone, of you who has a variant of uncertain significance, it's not that I'm saying that 90% of you are going to go to the likely benign side necessarily, but just that's what it ends up being with the large laboratories. And for most, at least in my practice, and I think it's probably the same for you, of those of you who have seen geneticists, I always tell my patients, I whisper in your ear, even if the laboratory is going to equivocate on this, I'll whisper in your ear based on my analysis and tell you if I think it's leaning one way or the other. And I actually, I don't know, at least for me, I usually end up being right about that. So if you're not sure, feel free to go back and ask your provider. I'll also say that in Simons Searchlight, and Caitlin, I don't mean to put you on the spot, but if you want to say anything about this, feel free to chime in. In Simons Searchlight, one of the things we do is we actually go back and re-review genetic variants that are in the community. So when we do see that some of these that are classified in one way, if we see that they get reclassified over time, because when, the collective knowledge of everyone studying GRIN2B and people sharing their information, that as we get smarter as a community, we do want to make sure that information gets updated over time. So we actually have within Simons Searchlight, as I said, a team of both geneticists and genetic counselors that go back and re-review that information over time. If they do see that a classification has changed, we actually get that information back out. And ultimately, the best way to do this is for us to, I saw this, the gene whisperer. So Michelle, we also whisper in your ear in terms of, we think this boost is now likely pathogenic. And so, we'll whisper that back to you. And then you can actually request from the laboratory that did your original testing to have that looked at again. And the advantage of doing that is that, number one, they can give you a second opinion. And number two, they can issue a revised report. And that revised report can be quite helpful so that whoever your doctor is that's looking at this doesn't say, just take Wendy Chung's advice or just take Simons Searchlight's advice. They said this. It's actually sort of real, it's here in writing. This is really saying that, GRIN2B really is my diagnosis. This really is the answer. So we do try and keep up with this. It doesn't happen every day, but we do try and on a periodic basis go back and look at everyone who's not completely adjudicated one way or the other.
Thank you. Other questions for Dr. Chung? Here from Brittany. You shared the slide that showed the location of variants. So what is the significance of where the variants are located on the gene? Can location tell us anything about basically an individual's phenotypes?
So this is a really good question. It's one of the things that I admit I'm looking at, and it's a hard question to answer until we get enough information. And I'm one of the challenges is that, and you guys probably know more than I do. If someone can answer, Philip or anyone else, you can shout it out. But I realize not everyone in the GRIN2B community is obviously in the data that I presented. Do you guys think your total Facebook community or the group that you know of internationally, do you think you're up to 300-ish, more or less? Maybe less, I don't know.
I would say that's fair.
Okay, yeah. So what ultimately happens over time is it's really, as you can imagine, a statistical thing in terms of being confident. So if you want to think about, there were certain amino acids that I showed you where we have not just one person in the community, but maybe 5 people. And so, that you could say, okay, well, look at all those 5 people and look and see, do they look the same? Because they've got the same exact GRIN2B change. So at least if you know that that's sort of anchored, if you know that's the same, then any variation you're seeing around that is just variation because everyone's unique. Everyone's different. They might be different sexes. They might live in different countries, whatever it might be. So that sort of gives you one sort of piece of information. Then, as you were saying, if you wanted to start look at genetic variations of all the missense, so just classify all those together, that's going to be heterogeneous. So ultimately, that's not the perfect way to do it. But then maybe you would say, well, look at this poor domain right here. And if I look at the I didn't show it to you, but let's pretend I could do the 3-dimensional structure of the protein, and we can do that. But let's take the 3-dimensional structure and let's see everyone, for instance, who might be exactly at this location within that part of the protein. Does that seem like everyone's the same as, for instance, everyone who has the exact same amino acid? Can we start lumping, if you understand what I'm meaning, aggregating or putting people together? So at some point, I do think we're going to be able to do that. We've done that for different conditions, different other, not necessarily just within the GRIN group or even just neurological conditions. And I don't mean to scare you, but some of the studies where I've done this with, particular conditions, we've gotten thousands of people within those communities. So, potentially, and it's taken us in some cases 20 years to do, but being able to get thousands of people together to make a robust statistical argument in terms of what's the same and what's different. Now, at the end of the day, why does this matter? There are people that are working that are really, really amazing scientists who are working to understand and see whether or not there might be a medication that'll work. And what I mean by medication is like a pill. So like a small molecule that might interact in terms of GRIN2B and might, be able to interact with a certain surface of the protein, for instance, and might want to be able to get in, just fit into a specific location. And it might be important to therefore know, is it going to have an effect for this region of the protein over here? And maybe we want a different molecule that's going to squeeze in just the right place for a different location on the protein over here. And being able to know that, and being able to know, we sometimes call this precision medicine or personalized medicine in terms of what effect that might have. And GRIN2B is a little bit different if you start talking across any of the other rare disease groups. To me, it's a little bit different and special in terms of the heterogeneity, the number of different genetic differences that we see in the gene. They are definitely concentrated within one location, but we see a lot of different genetic differences. And I think that's accounting for a little bit of the difference we see in terms of how people are doing, and might someday account for some difference in terms of how people might respond to a drug. So it's a little bit more complicated. Like I said, all the more reason in terms of inviting some of your friends within the community to make sure they're represented, because as researchers are trying to either come up with a medication or come up with a treatment, I've watched them do it. They will work on what's in front of them. If it's easy for them to do and, be able to pick it, order it, just click a button and order it, they'll do what's easy for them. So if you make it easy for them, they're more likely to work for you.
Thank you. Yeah, and I just to piggyback on that, Dr. Chung, just to everybody that is watching and participating in this webinar week that we're putting on, I think the common refrain to all of us is to participate in as many of these studies as we can, because we are an ultra rare disorder, and we cannot rely on thousands of other people to have it, to do the work for us. And I'm not pointing any fingers by any means, but I'm just saying, if you are able, and obviously Dr. Chung's presentation has shown that this is truly confidential. The only thing being really worked with are those genetic coded variations. And so the more everybody is able to participate, and hopefully Simons Foundation can work with some of our families that are from Canada or other countries where it may not be as easy to get those samples to them. The degree to which you can do that is so important, whether it's for the Simons Foundation study that Dr. Chung has presented on. There's also the patient registry that's being done with Dr. Tim Benke and Emory University. So there's so many different things that I think each of us can do to make sure that, as Dr. Chung said, we're in the studies. Any other questions?
I'll just point out that Caitlin put in the chat, for anyone that didn't see it, there's an email address called coordinator@simonssearchlight.org. So if you're stuck or confused about anything, you can email them, and they'll even get on the phone with you if you need to get unstuck. I also do want to put out a shout out for Tim Benke. He's fabulous. And everything that we're doing is very much working with Tim. All of the data he's getting access, not just access, I mean, he's getting the entire data releases every time we have one. And I know he's really appreciative of what all the families are doing.
Thank you. Okay, well, I want to thank again, Dr. Chung, for your time this evening, and also to Simons Searchlight. I want to remind everybody that is been watching this live webinar. There are other webinars that are available that are going to be, put out via social media throughout the week. But if you don't want to wait, you can watch about 5 other pre-recorded webinars, one of which features Dr. Benke. There is also some updates on our grant recipients. They can provide updates with their research. Dr. Caitlin Hudak has a update on her research. And then our most recent grant recipient, Dr. Hongji Yuan, also will provide updates with his research on some mouse model studies with a specific GRIN2B variant. And then if you're newly diagnosed, or if you're like me and you just have to have genetics repeatedly taught to you to make so that it maybe sinks in. Dr. Smith, who is a genetic counselor, did a wonderful webinar called Genetics 101 that is also available. And then, finally on Thursday, July the 22nd, there will be a live webinar featuring a GRIN2B parent panel titled It Gets Better, which will be a large sort of Q&A about anything kind of you want related to GRIN2B related neurodevelopmental disorder and what it means to be sort of a parent in the trenches as we kind of navigate through this together. So again, Dr. Chung, thank you very much for your time. Everybody else, thank you very much. And I wish everyone a pleasant evening.